Hello, this is Carolyn Ellaway. I'm a paediatrician and clinical geneticist at the Children's Hospital at Westmead in Sydney. Today I'm going to talk about the ear, nose, throat and respiratory complications of a group of disorders called mucopolysaccharidoses. During this presentation, I will talk about mucopolysaccharidoses, their clinical features, focusing on ear, nose, throat complications. I will also discuss how MPS disorders are diagnosed and also some treatment options. Mucopolysaccharidoses are a heterogeneous group of rare inherited lysosomal storage disorders. Each is caused by deficiency of a specific enzyme involved in the catabolism of large macromolecules, glycosaminoglycans or mucopolysaccharides. The enzyme deficiencies lead to progressive accumulation of partially degraded glycosaminoglycans in the lysosomes of almost all the cells of the body. This leads to significant cellular, tissue and organ dysfunction and the excretion of glycosaminoglycans in excess in the urine of affected patients. The severity of mucopolysaccharidoses depends on the type and amount of substrate that accumulates, but also these disorders are progressive. The mucopolysaccharidoses are multi-system disorders with both central nervous system and systemic manifestations. Children are usually born normally, but this is followed by progressive physical and cognitive decline and often premature death. Many patients die in infancy or childhood, and patients who survive into adulthood often have reduced life expectancy and significant morbidity. There are 7 distinct types of MPS disorders that have been identified with different enzyme deficiencies. They are primarily inherited in an autosomal recessive pattern, except for MPS II or Hunter syndrome, which is X-linked. Each MPS disorder is individually rare. For example, the incidence of MPS I or Hurler syndrome in Australia is around 1 in 100,000. But overall, the combined prevalence is not so rare, approximately 1 in 25,000. Australia's birth rate is approximately 300,000 per year, so we might expect around 12 new MPS cases per year. There is a broad continuum of severity and range of manifestations within each individual mucopolysaccharidosis, often making recognition difficult. The severe MPS I Hurler syndrome and the attenuated MPS I Shy syndrome represent the most severe and least severe presentations of the same disorder. Both are caused by the same enzyme deficiency. Hurler syndrome is used to define cases midway between the clinical spectrum. Hurler syndrome is characterized by onset in infancy or early childhood with severe somatic manifestations and death before 10 years of age. In contrast, Shy syndrome is characterized by normal intelligence, normal growth, mild somatic features and survival into late adulthood. Important factors that contribute to this clinical heterogeneity is the specific alpha-iduronidase gene mutation, the residual enzyme activity, environmental and other epigenetic factors. Children with MPS disorders can present in a variety of ways. Although many similarities exist, the spectrum and severity of disease manifestations varies between and within each MPS type. Most patients with a mucopolysaccharidosis share a typical appearance characterized by progressive coarsening of facial features, often macrocephaly, macroglossia. Some have corneal clouding. There may be short stature and skeletal abnormalities. Hepatosplenomegaly is prominent in a number of MPS disorders, as are inguinal and umbilical hernias. The MPS disorders are multi-system disorders. There's often cardiac involvement with cardiomyopathy and valvular disease, reactive airways disease, recurrent upper and lower respiratory tract infections. Neurodevelopment is often compromised with developmental delay, which is often global, cognitive impairment. Behavioural problems are a significant problem in MPS III or Sanfilippo syndrome. With progression, some MPS disorders are complicated by seizures and hydrocephalus. ENT and respiratory problems are very common in patients with mucopolysaccharidoses and are often some of the first symptoms to appear. Analysis of the surgical data from 544 patients enrolled in the MPS I registry, an international observational database, showed that 72% reported at least one surgical intervention before the diagnosis of MPS I was established. The most common operations were myringotomies, hernia repairs, adenoidectomy, and tonsillectomy. The most frequent reasons for referral for these procedures are not unlike those in the general population, such as recurrent otitis media, hearing loss, and upper airway obstruction. However, the complexity is greater and the age of initial presentation is often younger. The average age of children with MPS disorders undergoing adenoidectomy and tonsillectomy is around 2.2 years for Hurler syndrome, which is younger than the general population. Often these children have repeated procedures. Ear, nose, throat and respiratory problems are very common in the mucopolysaccharidoses. The ENT and respiratory disorders can be divided into otological disorders, airway abnormalities, alterations in respiratory mechanics. Combined, this often results in effects on sleep with obstructive sleep apnea, which eventually lead to hypoventilation and cardiorespiratory failure, a common cause of death in the MPS disorders. Children with mucopolysaccharidosis often have recurrent acute otitis media, chronic effusions. Hearing impairment is very common and when present is often of a mixed nature. While the conductive loss can be attributed to chronic effusions and eustachian tube dysfunction, the etiology of sensory neural component is less clear. It is thought that deposition of glycosaminoglycans may occur within the cochlear duct and cochlear nerve, sufficient to disrupt function and results in mild to profound hearing loss. Airway abnormalities are common. There may be a flattened nasal bridge, short neck, mandibular abnormalities, and abnormal cervical spine, particularly in MPS IV or Morquio syndrome. Oral manifestations include an enlarged tongue, gingival hyperplasia, mucosal edema, thick mucoid secretions, limited mouth opening with temporomandibular joint stiffness. There's chronic rhinorrhea and sinusitis. There is progressive deposition of glycosaminoglycans in the mouth, nose, pharynx, larynx and lower airways. As a result, there is tongue, adenoid and tonsillar enlargement, thickened secretions throughout the airways resulting in recurrent lower respiratory tract infections. Glycosaminoglycan deposition can also occur in the trachea and bronchial cartilage that can result in tracheobronchomalacia. Multiple abnormalities in MPS patients can reduce ventilatory capacity, such as short stature and skeletal dysplasia. Kyphoscoliosis and pectus carinatum are common and altered chest wall shape and structure. Diaphragm movement can be compromised by liver and spleen enlargement. The combined effect of these alterations, coupled with airway abnormalities, may lead to respiratory failure. Children with MPS present a major anaesthetic risk. There is often limited visibility during intubation caused by glycosaminoglycans deposition in the supraglottic tissues, excessive secretions, macroglossia, reduced size of airways, and unstable atlantoaxial joints. There is often restrictive lung disease and cardiac disease, so general anaesthesia should only be performed by anaesthetists experienced with these disorders. The MPS I registry collects observational data to track the clinical progression and management of patients with MPS I among the global patient population. As of June 2013, just over 1,000 MPS I patients were enrolled from over 30 countries. The goals of the registry are to contribute to the medical understanding of MPS I and improve the quality of care of these patients worldwide. A study was performed to characterise airway-related symptoms and surgeries among patients in the MPS I registry in relation to diagnosis of MPS I. The most commonly reported symptom was sleep disturbance at a median age of onset of 1.5 years. A high proportion of symptoms were reported prior to MPS I diagnosis at a very early age. The average age of diagnosis of patients within the registry was 1.4 years, with a range of 0 to 44 years. The median age of onset of reactive airways disease was 1.6 years, of macroglossia 1.9 years, and enlarged tonsils 2.7 years. This graph demonstrates the proportion of registry patients reporting airway symptoms. Airway symptoms are present across the MPS I clinical spectrum in a high proportion of MPS I patients. The next graph shows the proportion of registry patients reporting airway-related symptoms before the diagnosis of MPS I. Overall, approximately 1/3 of patients were reported to have macroglossia, enlarged tonsils, and/or sleep disturbance. A smaller proportion had reactive airway disease prior to the diagnosis of MPS I. This graph shows the percentage of patients with airway surgery at any time. Most of the surgical procedures were performed to alleviate upper airway obstruction. The most common procedure was adenoidectomy and tonsillectomy. And finally, this graph shows the proportion of MPS I patients reporting airway surgery prior to diagnosis. A total of 665 airway-related surgeries were performed for 387 patients, ranging from 1 to 14 surgeries per patient. Many patients, including the majority of shy patients, had at least one airway-related surgery before diagnosis of MPS I. Adenoidectomy and tonsillectomy was the most common surgical procedure, being performed in 25% of all patients prior to the diagnosis of MPS I. Biochemical diagnosis of the MPS disorders is established by a variety of assays in urine, blood, and cultured skin fibroblasts. These tests are performed in a few specialised laboratories in Australia. Quantitative urinary glycosaminoglycans are useful for screening. Elevated glycosaminoglycans are followed by electrophoresis to identify the substrate excreted and to determine the specific lysosomal enzyme to be tested. Once the specific disorder is identified, mutation testing of the relevant gene can be performed. Prenatal testing is available either by measuring enzyme activity or mutation testing. This can also lead to testing of other family members. Neonatal screening protocols for MPS disorders as a group are being developed, but are not currently performed in Australia. The mucopolysaccharidoses are best managed by a multidisciplinary team with care coordinated by an experienced genetic metabolic physician. The early recognition and prompt diagnosis of MPS is crucial, as outcomes of treatment in many cases are time-sensitive, with better results achieved when intervention is initiated at a young age or prior to the progression of the disease. In addition to managing the individual symptoms and complications, specific treatments aimed at treating the pathological process are available for some MPS disorders. Hematopoietic stem cell transplantation is used to reconstitute a patient's hematopoietic system with normal cells that produce the deficient enzyme. Hematopoietic stem cell transplantation has been successfully reported in MPS I. Early transplantation before 24 months of age and prior to the onset of neurological disease can prevent CNS involvement, reduce organomegaly, improved cardiac function, growth and airway obstruction. Eye and skeletal disease, however, are not significantly improved. Hematopoietic stem cell transplantation has led to reduced morbidity and mortality. However, preconditioning with ERT and support during the first 120 days post-transplant in MPS I and MPS VI has further reduced morbidity and mortality. Enzyme replacement therapy replaces the missing enzyme exogenously through repeated enzyme intravenous infusions. ERTs are commonly or commercially available for MPS types 1, 2 and 6. The inability of enzymes to cross the blood-brain barrier precludes the use of ERT for CNS disease. Ear, nose, throat and other airway-related symptoms are common in the mucopolysaccharidoses. Many patients have airway-related symptoms and associated surgery before the diagnosis is established. This highlights the important role of paediatricians and ENT surgeons in recognising the early signs and symptoms of MPS disorders. Early diagnosis is vital. Effective treatment is available for some MPS disorders, making it possible to prevent irreversible disease-related damage. Thank you.